So we've been talking about systemic agents for tumor control. Let me turn to James. There have been some new drugs that have come up in the past couple of years for treatment of neuroendocrine tumors. You want to give us just an overview of what's available now?
Yeah, absolutely. I think this is a very exciting area because for a long time we really haven't had anything new. And in 2011 we had 2 new drugs approved for pancreatic neuroendocrine tumor. So in that area I think we are making some progress. One of the drugs approved was everolimus, it's an mTOR inhibitor. It's based on a study that demonstrated improved progression-free survival, the median by 2.6 folds. And the drug generally is fairly well tolerated. Previously was used for organ transplantation and also as well, so there's a large safety record. The other drug that was approved was sunitinib. It's a VEGF inhibitor, decreased tumor blood flow to the tumors. And again, the study demonstrated improvement in progression-free survival as well. And so now we have 2 new agents for this group of tumor. So one question always comes up is, how do you select these agents, new agents? In my mind, a third option here is also cytotoxic chemotherapy. So for me, these targeted agents, I tend to use them first for people that has moderate volume of disease, and especially if they have progression. And for people who have very heavy volume of disease that you really need cytoreduction, maybe chemotherapy. And between these 2 agents, I think the differences are when seeing side effect profiles. So if you have someone who have bad lung disease, bad COPD, then perhaps the VEGF inhibitor is a better way to go. Or uncontrolled diabetes would also make you a little bit more cautious about using a mTOR inhibitor. On the other hand, if someone has cardiovascular disease or hypertension and so forth, I think everolimus would have a better match for these patients. The other part that's a little bit different is that for the mTOR inhibitor, everolimus, there's also data that the treatment with these drugs can decrease hormone secretion from the tumors. And especially for people with insulinomas, it can be a really remarkable difference. So functionality of the tumor can also help you to make some decisions about what to start with first.
Let me turn to Pam. We have got these 2 drugs. They both improve progression-free survival. There's a lot of debate about which one you use first and second. Do we know anything about whether patients do better with one or the other, or do most of your patients get both?
So I think that's a great question. I think we don't know the answer to that yet, but it's a common one that I get asked by community oncologists is, what is the correct sequence of treatment? Whether it's a somatostatin analog first, that sometimes will inherit patients from the community who are on those, or a cytotoxic agent, or some of the targeted agents that you mentioned. And I think that I tell most of my patients that they'll probably see both of those targeted agents in their lifetime, and that we don't know the answer in terms of sequence. And like James, I make choices maybe based on patients' comorbidities in terms of choosing one versus the other first.
One of the other things that was really remarkable about both of the studies, James, is the fairly impressive improvement in progression-free survival. But when you look at the response rates, they're not terribly impressive. How do you interpret that?
Yeah, well, I guess the way I would interpret that is that if you really look at what really matters, to me, neither response rate or progression-free survival are self-evident benefit. So then it becomes, which one is more likely to be a good surrogate for a real benefit like overall survival. I think most of the oncology community believe now progression-free survival is probably a better surrogate benefit. And it's not unique to this disease. We see the same thing with renal cell carcinoma and the HCC, that some of these newer targeted agents may not have a big response rate but can lead to real benefits. The bottom line is that in this disease, because it's fairly rare, the number of patients required and so forth, we're not able to do overall survival benefits. And so I think progression-free survival is probably the best surrogate we have.
Maybe just to give even an anecdote with regard to how well or how poorly these drugs are tolerated. how long have you had patients on, let's say, everolimus?
So the longest patient I have on everolimus is one that, we started a clinical trial a number of years ago before the drug was commercially available. It's a patient with a small bowel carcinoma tumor, and he's been on for over 5 years now. He's tolerating treatment very well, and actually has some, continued, slow tumor shrinkage over a very long period of time.
I have 2 patients in the RADIANT trials that are at 5 years as well. And I think in this disease, stable disease is king. Some of the more dramatic responses that I have seen, whether it came from everolimus, sunitinib, or chemotherapy, it's wonderful while it lasts, but once it escapes, the tumor seems to grow back just as rapidly. And I think in some diseases, having a great response doesn't correlate with good long-term survival. And I think this is one of those.
It's true. I could, one of my own anecdotes, a patient on sunitinib now for over 4 years and doing okay. So it can be quite amazing with what one can get with the targeted drugs.